Good morning, everybody. I'd like to welcome you to the webinar we are holding this morning on World Suicide Prevention Day. And the theme for World Suicide Prevention Day is creating hope through action. And the webinar today is focusing on the National Suicide Prevention Trial that was the evaluation of the National Suicide Prevention Trial that has been that was carried out here in the northwest of South Australia. Before we move along, I would like to acknowledge the traditional custodians of the lands across Australia and pay respect to elders past and present and future. We recognise and respect the unique cultural and spiritual relationships to the land, waters and seas, which continue to be important to Aboriginal and Torres Strait Islander people living today. We would also like to acknowledge those and/or mental ill health for their valuable contribution. These people generously shared their personal experiences to support mental health and wellbeing in our regional communities. I've also received a couple of apologies from Kim Thomas, Nukanu Elder and Chair of the Country SA National Suicide Prevention Trial Steering Committee. Kim can't be with us today as he is travelling interstate to be with family. I've also received an apology from May Walker Jeffries, who is a local woman from Whyalla. And before I move along, I probably should introduce myself. I'm Lee Martinez. I'll be chairing the webinar today. I'm a mental health academic with the Department of Rural Health, UniSA, and have lived and worked in rural South Australia for most of my working life. I'm also the Secretary for the Wireless Suicide Prevention Network. I'd also like to ask people throughout the webinar to write any questions they have in the chat function throughout the webinar, and some questions will be answered in the Q&A session. And a reminder that if this discussion raises any issues for you, or if you need immediate assistance, please reach out to Jess, who is working and supporting us in the background, Jess Roach, via the chat function. Sorry. Now I'd like to invite Rowan Ramsey to, who's the member for Grey, to welcome us as well.
Very good. Can you hear me, Lee?
Yes, I can, Rowan.
Oh, that's good because I've been struggling to get unmuted, and I've written notes and all kinds of things to hold up to people. So, well, there you go.
Oh, so you're all good.
Very good to be with you this morning, and it's quite an exciting day. The release of your results on this program. I was wondering what I was going to say in my short time allotted, but I think in many people's view that parliamentarians or governments sort of sit apart from their communities. I can tell you it is not the case. We all represent electorates, in some cases large electorates, but we all come from somewhere. We all come from home. And I don't think there's anyone over the age of 20 that hasn't come into contact at some stage or another with suicide and the impacts it has on families and communities. I come from a little town called Kimber. There's a little over 1,000 of us there in the whole community, and I thought back about it. There's been 6 suicides there in the last 35 years or so, and I had a bit of a check on the national suicide rate, so that puts us above pro rata. Not a lot, but probably 25%. But every one of those 6, because it's a small community, we know them. We know them personally. In one case for me, it was a close friend. And I think that's the thing about suicide. It's somebody else's problem until suddenly it's on your doorstep. For those of us who never entertain such thoughts, such dark thoughts, it's difficult to understand, I think, how anyone ever gets to that place. But they do because the results are there. I'm also the member for grey, which covers all of the remote Indigenous communities in South Australia. We know that we have a particular issue there in those communities. And while this trial hasn't been focusing on those, let me say that something's gone wrong here. No, that's better. One of the things that do concern me is the sort of contagion that we see where we'll get an outbreak of suicides in a community, and we could all talk about why that might be, but I think it deserves consideration. In Kimba, and I don't think we are so different to any other community, but I raise it because it's my hometown, there's been some very positive actions. We have a Kimba mental health and wellbeing committee that works very hard to bring these issues to the fore in the community, and they work very hard to attract funding from the Faye Fuller Foundation for Our Town project, which is operating in Kimba, Cummins and Ceduna, focusing on mental health issues within the community. That'll run for 10 years, so it's a very big win for the community, and hopefully try and get the message out there, try and get people talking about the issues in their life that would drive them to such a desperate place. Just in overall terms, and I better not go on too long, under the guidance and suggestion of Pat McGorry, Headspace units were begun to set up under the Howard government. They were expanded under the Labor government, expanded again under us. There are now 115 of them across Australia. And in grey, we have 4. There's one just been upgraded in Port Lincoln to a full site, in Whyalla, in Port Augusta, and then the second one that operates out of Port Augusta through the RFDS in an outreach into the outback communities. I am strongly campaigning to try and get one in Port Pirie. I think that's the missing piece of the jigsaw at the moment. And then we could talk about where we go after that. But they, I think, have proven to be quite effective. McGorry actually wore quite a bit of criticism up until a few years ago about early intervention, but I think the chickens are coming home to roost now. And I think that dovetails into the work that you have been doing, Primary Healthcare Network, through these suicide prevention trials. Now we've got this data coming in. We've also got this large injection of funds, $2.3 billion coming through the federal budget, which I think there's around about 200 million. I've got it written down, 300 million that is put aside specifically for suicide prevention. So I think we can all expect that you, the people that are in on this meeting this morning, will have much more work to do in the future. I would love to be able to say you've got no more work to do. It'd be so good with many things that we deal with if we could put it behind us and say we've solved the problem. We haven't, and I suspect maybe we never will on this one, but we can certainly improve it. So thank you so much for the work you all do, the work participants in particular, but others that have worked so hard on this trial. May the results, along with the other 11 sites around Australia, provide good guidance to those people in Parliament who come from little communities and bigger communities like this fellow does, the one I've talked about, so we can make sensible decisions for all Australians because we're all affected. Thank you.
Thank you very much, Ryan. That was a lovely introduction and really painted the landscape of the rural South Australia area that we all live in out here. I'd like to now welcome Shay and Nicholas, and Shay will then introduce herself and Nicholas. Thank you.
Thanks, Lee. Thanks, Rowan. Country SA PHN, in partnership with the Uni SA, welcomes and thanks everyone for joining us today. We are pleased to share the learnings from the National Suicide Prevention Trial in Country SA. The Commonwealth-funded trial sites, which were 12 in total, were placed at a regional level to better understand local and respond to local needs. The initiative was focused on trialling systems approaches to suicide prevention, but tailoring to the needs of their own communities. The trial has been evidence-informing and resulted in new services and resources being trialled and evaluated. We've seen increased sector and cross-jurisdictional collaboration, but most importantly, our localised strategy and activities created an evidence base which has informed future funding and policy direction at both the state and national level. The landscape has been forever changed, And we thank the over 774,000 people that were engaged in community activity, education and training, awareness raising, and all the support services funded under the Country SA PHN trial site. Today's webinar presenters, today we have Mr. Richard Parker, an incredibly talented and intelligent and humble lived experience representative who has the ability to capture a whole of communities and reduce stigma through his storytelling techniques. Talking also will be Professor Nicholas Proctor, who really does require no introduction. Nicholas is the Director of UniSA's Mental Health and Suicide Prevention Research and Education Group. He is currently Australia's National Representative to the International Association for Suicide Prevention and holds many senior independent advisory roles, including to the Office of the Prime Minister's National Suicide Prevention Task Force. And we're going to have to stop there, Nick. We could talk about you a lot more, but we're going to have to move on. Dr. Kate Rhodes will be joining us. She is an experienced mental health clinician and academic. Kate is active in the development, delivery and evaluation of mental health programs within UniSA's clinical and health science. And presenting some of our youth finding is Hayley Collier, who's been the Suicide Prevention Officer for the Country SA PHN trial. And without her involvement, none of this would be possible. She's done a lot of heavy lifting over the last 5 years. And of course, you'll have me throughout the webinar, Shay Kerner. I'm the Manager of Mental Health and AOG for Country SA PHN. And over to you, Nick.
Oh, thanks very much, Shay, and good morning and welcome, everyone. Today, as you know, is World Suicide Prevention Day, and the theme for World Suicide Prevention Day is creating hope through action. And if we think about it, and it goes to the very heart of the trial, suicide can affect every one of us. Each year, suicide is a devastating and has a profound impact on those around them. However, by raising awareness, reducing the stigma around suicide, and encouraging well-informed action, we can make a difference. We can reduce instances of suicide in country South Australia and across Australia indeed. So it's those little actions, it's those thoughtful actions, it's those compassionate actions, no matter how big or small, that may provide hope to those who are struggling. And, you know, prevention of suicide is often possible, and you can be a key player in prevention. So this message of action, through action, you can make a difference to someone in their darkest moments. And as a member of society, as someone in the sporting club, someone at school, as a child, as a parent, as a friend, as a colleague, even a neighbour, we can all play an important role in supporting people in critical moments of the suicide experience. So a great day to have a discussion, come together, bringing people from different parts of the workforce, different sectors, really to talk about ways of creating hope through action, and which is the theme for World Suicide Prevention Day. So thank you. Back to you, Shay, Lee.
Thank you, Nicholas. I'm going to move into the consultation findings now under the suicide prevention trial. But before I do that, in the office with me today, I've got Mr. Stephen Monaghan, who's the COO of Pikauiya Aboriginal Health Service Corporation. And Steve and his team played a really important role in some key strategic activity. Steve does have some other commitments, so we'll see how long he can stay with me, hopefully long enough to help out with the aftercare evaluation. We'll see how we go. Between late November 2017 and February 2018, Country SA PHN conducted consultation workshops along with online surveys as part of the trial throughout targeted catchments in the locations that had been identified. It was the largest scale in-place suicide prevention consultation regional South Australia has ever seen. It was placed at a local level, a regional level, to better identify and understand and respond to local needs. The themes and priorities identified through the consultation process were used to provide a snapshot of perceived gaps and service needs within the trial. These findings then formed part of the needs assessment, which was overlaid by additional regional state data sets, key stakeholder and sector engagements, all to inform Country SA PHN's decision making and commissioning of all NSPT activity. So sometimes we'll say NSPT, which is short for National Suicide Prevention Trial. After all of the consultation was done, the key gaps that were highlighted within suicide prevention for the trial site were: follow-up care after a suicide attempt, and it was really about appropriate suicide prevention care pathways for people in regional South Australia's stigma surrounding suicide and suicide attempt. Regional South Australia felt like that was still a significant issue and barrier to overcome. The community spoke really well, and the data showed that suicide prevention training opportunities was needed. Communities wanted to know how to recognise and respond to people in distress in their own regions, and workforce collaboration was the last one that was the major key gap identified. That need to increase the support and shared care arrangements at critical transition point for clients. I think now we're going to go to Kate, Dr. Kate Rhodes, who's going to talk around the key findings from the evaluation.
Hi everyone, I'd just like to say thank you and echo the acknowledgements of Aboriginal peoples and people with lived experience today. I'm speaking from Kaurna country, and I'm a lecturer and researcher with the Mental Health and Suicide Prevention Research and Education Group at UniSA. So just on to the next slide, which I'm having trouble with that, Jess. Can you progress it for me?
That should work now.
Okay, let's have a look. Sorry about this. Oh, now it's gone. Too many. There we go. Okay, thank you. Sorry about that. So first of all, just like to talk about the importance of the issue of suicide prevention is that 1 in 5 people each year will experience a mental health problem, and 5% of all Australians will experience some form of mental health problem in their lifetime. So it just shows how widespread it is. People in rural and remote regions are affected more so by suicide, and the statistics back that up, than people in urban areas, and partly that's due to isolation, things like the drought, bushfires, the overlap of the pandemic, and subsequent financial hardship can all take its toll. So Country SA PHN focused on 5 population groups in the following South Australian local government areas, and they were Port Augusta, Whyalla, Port Pirie, Port Lincoln and Yorke Peninsula. These population groups were appropriately targeted as the highest proportion of suicides in 2019, and they occurred in young and middle-aged people. So that is young people aged 12 to 24 years, adult males aged 25 to 54 years, and Aboriginal and Torres Strait Islander peoples who were evaluated separately. So the evaluation aimed to understand what strategies were most effective in preventing suicide for at-risk populations in these regions. There we go. So the overall findings, the evaluation findings are very positive in response to the community events initiated by the Country South Australian PHN trial strategy. So this is shown by the community consultations done at the start of the trial that Shay has just talked about, and how many of these needs were addressed by targeted community events and suicide prevention training interventions. So there was quite a wide range, and these ranged in their scope from clinical aftercare services to suicide prevention training to awareness raising community events. So here you can see some of the activities, events and services that occurred during the trial and the aims associated with these. So some were awareness and stigma reduction, education and training, and treatment and crisis support following a suicide attempt. So UniSA subsequently evaluated the trial in 3 phases. So we examined retrospective data in phase 1, conducted a survey of past participants in phase 2, and asked participants for their feedback with focus groups in phase 3. I think this is advancing too quickly. There we go. No. Can we go back a couple of slides, Jess? Sorry, I'm having trouble with doing it. And perhaps if you can do it for me, it will be easier. So on to slide 6 is the one I was talking to. Yeah, that's right. So that's where I'm on now. So we've evaluated a trial by doing the retrospective data analysis, and conducted a survey, and then also conducted focus groups. So our work started in October 2020 and concluded at June 30th this year. So in phase 1, we evaluated data collected from 2017 to 2020 about variables ranging from suicidal thinking, depression and hopelessness, to confidence in helping, increased knowledge and skills, usefulness of training, and acceptability of presentations to determine which community events and activities and aftercare services worked best. In the first phase of the evaluation, our research team reviewed surveys collected before and after training. And here's a snapshot of the perceptions of 2 pre and post training courses. And it's clear from these results at the time of participation, people found these training programs useful, both in terms of increased confidence as well as knowledge and skills building in suicide prevention. The rest of the training activity results can be found in the full evaluation report, which is being launched today. So out of the 56 community events we evaluated in the survey in phase 2, the events with the highest engagement are listed here. From an evaluation perspective, the University of South Australia sent a questionnaire to anyone noted as participating in a community event and or training program. This survey was used to better understand trial program attendees' attitudes to suicide and confidence or competence interacting with people at risk of suicide since attending the trial activities during that time between 2017 and 2020. Many people participated in more than one of the 56 community events or activities in the trial region, and the research evaluated which suicide prevention strategies worked best across key variables, what improvement outcomes occurred because of the trial strategy, and which activities had the greatest community impact across the trial region. Focus group discussions and interviews were also held in the final phase of the evaluation to explore people's retrospective experience of their attendance at trial community events. That is, any subsequent changes in attitudes towards suicide, any increased confidence in interacting with people at risk of suicide, or awareness of local suicide support networks in their PHN region. Results reinforced the positive effects of the community events, particularly in relation to populations in regional South Australia. Given the high incidence of suicide in regional compared to urban areas, we recommended that the community events most valued by the individual communities be retained and funded in an ongoing capacity. So next slide, please, Jess. Firstly, it should be noted that the results show positive responses to all of the most attended community events, including positive scores in relation to knowledge attainment that suicide is preventable. And that was particularly noted by the coasters, suicide risk factors and suicide warning signs, reducing stigma, how to refer people in suicidal distress for professional help, increases in compassion, increases in confidence to help others, and intentions to seek help for oneself, and intentions to seek help for oneself, and also helping others seek help. So that's 2 separate things. Understanding cultural difference, sharing by recommending events to others. So those things all rated quite highly. For example, the suicide prevention drink coasters rated the highest for understanding that suicide is preventable. Oh, yeah, I just said that, but did not rate highest on any of the other factors. So which might indicate that the intended message of the campaign was to address this point. And if so, it was very successful in doing that. QPR, the question persuade refer training, rated the lowest, which is the most favourable response to stigmatising attitudes towards people who talk about suicide. Therefore, QPR training might be the best option when targeting stigma reduction in the community or your chosen organisation. GPEX training had the best results for increasing knowledge around the warning signs of suicide, and this may be relevant for clinical or frontline workplace applications. The Ripple Effect documentary scored the highest on all of the other suicide prevention factors that we examined in the survey, which included compassion, confidence to help oneself and others, knowledge of risk factors and cultural difference, and where to refer a person to appropriate services. The documentary also was most highly rated for recommending the event to others. Okay, next slide, please. So for aftercare services, the incidence of mental health conditions by primary diagnosis was depression related, and the highest medication type was antidepressants. Total depressive symptom scores reduced over time from episode start, review and end, showing the success of aftercare services treatment, as this figure shows. So these are depressive symptoms. It goes up to a score of 50, which is off that chart. But as you can see, as each individual had an episode of care, that means they had more than one visit to an aftercare mental health professional over a period of time. So that was their symptoms at the beginning of the episode of care when they were most unwell. And then over time, at episode review and then at episode end, you can see how the depressive symptom scores have reduced. So next slide, please. So 98% of people we talked with in the focus groups, including those who accessed aftercare services, reported that attending a trial activity or event had impacted on them in a variety of ways. So from these focus groups, there was reported an increased awareness of suicide and suicide prevention, a decrease in judgment and stigma, an increase in confidence and competence to openly communicate and connect with those in suicidal distress, an increase in compassion, a determination to help and make a difference. And some people told stories where they interrupted suicidal pathways of those in distress. Subsequently, there were flow-on effects within communities and increased capacity building in suicide prevention as people put their new skills into practice in their everyday lives. There was also support for suicide prevention activities, with examples of businesses partnering with service providers to run well-being events, and things like the world's biggest comic book. Even when it was time to pull those down, some of the businesses wanted to retain those big images on their buildings. So the most effective activities appeared to be Living Works Assist. This is from the focus groups, Applied Suicide Intervention Training, the Drink Coasters, the World's Biggest Comic Book, Stand Up for Mental Health, and QPR. So if we can just go, oh no, hang on, that's okay. So just still back on the previous slide, sorry. So those were the most effective activities, but there was still a stated increased consciousness that suicide doesn't discriminate and that can be preventable. As highlighted by one interview, people are no different. We all go through the same things and it can affect any one of us. The first responders events, while a smaller sample provided a voice, were extremely impressed with the events and considered these activities essential for engaging first responders, many of whom identified as male. The Rotary men's events were highly valued and most of the men's road shows were also reported favourably. Okay, next slide, please. Yeah. So finally, the recommendations from the trial evaluation can be summarised as follows. So the suicide prevention training, the data suggests targeting specific training needs with the most appropriate service type that address the corresponding community need. So that just means listening to the communities and find out what service type of service training needs they require, which will change and be different between different communities. And with community events, given the higher incidence of suicide in regional compared to urban areas, it is recommended that community events most valued by those individual communities be retained and funded in ongoing capacity And I think it's important to build on the momentum that has been achieved by the trial and maintain the shift in attitudes towards more compassion towards people who experience suicidal states, increased help seeking and offering, reduced stigma, and attending aftercare services. So the aftercare service data suggests service provision is effective in reducing and maintaining depressive symptoms at low rates. If you refer to the scores in the proper full evaluation report, where depressive symptoms contribute to the highest scoring mental health conditions, and medication for depression are the most used of the medication types. Therefore, continuation of these services is recommended as well. So that's it from me. And now I'll hand back over to Lee. Thank you.
Thanks. Thank you, Kate. An excellent summary of a very, very large report. I'd like now to take the opportunity to introduce Steve. Steve Monaghan, who's going to talk about the Aboriginal Aftercare Service evaluation. And Steve is the current CEO of Pikauiya Aboriginal Health Service. So welcome, Steve.
Thank you very much.
Thanks, everyone. Jess, I might get you to click through the slides for me if you can, if that's all right. Yep, thank you. So firstly, we want to acknowledge and support the Aboriginal and Torres Strait Islander people. If you can move through the slides, Jess, sorry. Thank you. We want to acknowledge and support the Aboriginal and Torres Strait Islander people whom participated in 8 months of consultation whilst this was carried out on Nukunu country. We acknowledge that Aboriginal people from many nations contributed to the design and establishment of the Aboriginal Aftercare Service in Port Augusta, which really did come out of a consultation piece back in 2018. We would also like to thank the University of South Australia's Department of Rural Health for undertaking the evaluation of the Pikauiya Aboriginal Aftercare Service model with assistance, advice and guidance from the evaluation reference group that was inclusive of the Flinders and Upper North, LHN, Thrilly and Beyond Blue. And importantly, we also acknowledge and thank those with a lived experience of mental ill health and or suicide who generously gave their time and contributed their experience and perspectives as part of yarning and or interviews and or importantly by consenting to have their de-identified data shared with this evaluation. The purpose of the evaluation was to review the performance of the Aboriginal Aftercare Service model that had been implemented in Pikauiya in Country SA. Steve joins us today from Pikauiya Health Service Aboriginal Corporation. We thank Steve and his team for their courage and innovative practice in establishing and operating the aftercare service and participating in the evaluation. It was a piece of work for a long time, wasn't it, Steve?
It was.
Lots of players. The evaluation adopted a participatory approach in which embedded elements of evidence-based co-design to enhance local ownership of the evaluation process and finding, which was really important to the local community. And for those that are interested, you can find more information about the evaluation design, method and methodology in the Aboriginal Aftercare Executive Summary, which will be available to everyone. Jess, if we can move on to the evaluation findings slide now, thank you. That one's the design methodology. Excellent. The service experienced challenges, as all services do, new implementing ones, but these guys really found some challenges around collecting the episode outcome measures at the closure of an episode. And Steve's team felt that this was indicative of the need for more work to be done on culturally appropriate outcome measures and also collection methods as well, being more agile around how that can be done, whilst knowing that we also had to be conscious of the primary mental health minimum data set, which was also a factor in data collection. Despite this shortfall, the episode and the challenges, the episode data collected suggested that the aftercare service was effective in mitigating suicide attempts or deaths by clients that had received the support. A small proportion of the clients re-entered the service or had repeat episodes. The finding is important. It's really important, this finding, because we know that from the minimum data set that the service was supporting a particularly vulnerable population group, as 73% of the clients had reported having a previous attempt or suicide ideation with no attempt. Anecdotal evidence gathered from interviews of staff and other service providers suggests that there's a decline in reported hospital admissions to the ED for clients of the aftercare service over the reported period of 1 January 2019 to 31 October 2020. It also reported that there had been no deaths to suicide by clients of the aftercare service during this time, which is a really fantastic outcome. The evaluation identified 4 key elements of the aftercare model which are important for improved client outcomes. They are immediate and assertive follow-up, ongoing risk assessment and planning, assistance to adhere to treatment, and also solution-focused counselling. I guess we've always known that a previous suicide attempt is one of the greatest indicators for future and subsequent suicide attempts. So it's no surprise that assertive outreach was important and found as one of the effective strategies. Assertive outreach and distress intervention with a specific focus on reducing suicide behaviour and risk, as well as the identification of potential triggers, was seen as having a strong influence and positive impact at that point of time, but also importantly on what happened with other interventions that were to follow. Clinical and non-clinical approaches, embedding traditional complementary medicines as part of the suicide prevention care package alongside the medical model, demonstrated responsiveness to cultural needs, and the beliefs of clients blending therapeutic approaches was perceived as being effective in improving suicidal behaviour and enhancing motivation, health, and the well-being of the whole person. The length of care was really important to the participants and the community and was extended beyond the traditional 3 months of service, which is often seen in mainstream service. And this was important given the complexity of the presentations and also the geography in which people were presenting from. Clients were given access to the service for up to 6 months if they needed, and they could stay connected and remain connected to support. Noting that flexibility of mode and location of the service contracts strengthened with client engagement over time. The importance of kinship efforts to prevent suicide was frequently mentioned during yarning sessions with participants of this evaluation. It was also noted that the Aboriginal working group that was involved in the co-design of the model had really insisted right up front back in 2018 that there needed to be recognition and inclusion of kinship. The aftercare service was able to operationalise the need for involving family and carers into their care, and Steve and his team worked through the governance considerations for that. The inclusion of family members and carers was seen as promoting a holistic approach to client recovery, which was important for the client and also the community. The community and service delivery model was identified as being preferred provider as an Aboriginal community controlled health organisation for the aftercare service. This was seen as promoting a unified governance and management structure. Furthermore, the involvement of an ARCHO was perceived as enhancing client access to primary care services, including specialist care that could also be provided by PICAWI's GPs, visiting psychologists, and also psychiatrists. And the co-location with the social and emotional wellbeing team really enhanced the efforts of the aftercare service. It was reported by staff and also other service providers that the two services were able to complement each other. Shared care of common clients consisted and happened between their teams. And also it was reported that potentially a standalone aftercare service may not be able to achieve the benefits of a more connected, compassionate response that identified supports and supports people earlier in distress. And that was really important. And lastly, there was lots of findings around the service pathways, and notably that postvention became entwined with prevention in measures to mitigate suicide attempts and suicide ideation for Aboriginal communities. The Aboriginal Aftercare Service and Steve's team really played an important and assertive role in supporting postvention services clients and their families when suicide crisis presented. Steve's going to talk to some of the elements of the service that was thought that might be enhanced or could require some improvement.
Yeah. Thanks, Shay. Obviously, some of the improvements that came out of the trial was that extended hours of operation. Obviously, clients don't only have suicidal ideation or thoughts during business hours, and a lot of them will present to ED late at night, early morning hours and weekends. And there's a lot of contributing factors for that as well, whether there's drug and alcohol involved or DV issues, relationship issues and so forth. So that was basically highlighted as something that could improve the service, being a 24/7 service and a weekend service. Obviously, the logistics and the funding for that would need to be looked at and would be quite significant compared to what we're doing now. Some of the other issues were culturally appropriate outcome measures. So obviously the CIDES and the K5, K10 is often hard for our clientele to understand. So it's imperative that we have an Aboriginal health worker or support worker there who can actually explain some of the questioning. And if we can actually probably make some of the questioning a bit more culturally appropriate. We found it fairly difficult to get our clientele to be involved in CIDES and the K5's requirements. And that, various reasons for that, whether there was some shame or they just didn't understand the questioning. And often they just didn't want to do it. Other issues were around trying to locate our clients. Often they're lounge hopping, living rough, sleeping rough. So locating them and keeping an eye on them was extremely difficult. And then another thing we noticed was we were starting to see a lot of youth, younger people that were still going to school, teenagers and so forth. And they were finding some of the other services that were more appropriately set to deal with youth suicidal thoughts and issues, mental health issues, didn't appear to be as culturally appropriate as what we were offering at Pika Weir with our suicide aftercare team. So we started seeing all these younger kids, and we had to liaise a lot more with Headspace and CAMS and try and develop a system where the Aboriginal youth could be access services a lot quicker than they actually were. So we did assist quite a number of our youth in that regard.
The other thing that I think Steve is keen to talk about is some evaluation findings that were the unintended or unplanned positive and negative findings and the consequences of the aftercare service within Pika Weir, and the evaluation findings that were interesting around the medication management, wasn't it?
Yes. First, we have a pharmacist on site at Pika Weir pretty well Monday to Friday now. It was extremely handy to have them involved in home medicine reviews for a lot of our clients that were on antipsychotics or anti-anxiolytics. So that was a real positive. And having GPs on site and clinical psychologists 2 days a week also added to the service capability. And on top of that, we have a visiting psychiatrist once a month, and often he'll come up with a registrar as well. So we actually had a lot of avenues for referrals within our own service, which was culturally appropriate or seemed to be culturally appropriate, which I think really helped our service in maintaining the clientele and maintaining contact with them. And obviously with these clientele, if they resolved their issues and something down the track triggered another episode, we were able to pick them up again. So, and we knew their history. So those sort of things really exemplify the service provision that we were able to provide at the time.
And the other one that was interesting, Steve, was really around the integration with state and government housing support services. It was an area that you had to play a significant role in that wasn't identified earlier on, or wasn't something that you thought you would really be diving into in a really big way.
Yeah, that's right. Obviously, with our service, with the team, getting clients to appointments, food hampers, salvos, being involved with salvos, emergency accommodation was one of those jobs that was obviously picked up and was extremely excessive. Like a lot of our clientele were, like I said, have been living raft and lounge hopping. So housing and developing those networks with government and non-government organisations within Port Augusta had to be built from scratch and has been quite successful, but there's a long way to go yet with our housing issues too. But we're getting there.
Absolutely. And some of the findings were really impressive under the Aboriginal Care Service delivered by Steve and his team. And in conclusion, what the evaluation really did show was that the Aboriginal Aftercare Service was closing a service delivery gap for Aboriginal people in Port Augusta, and it was found to interrupt the trajectory of suicide for its clients, which was really excellent. It is providing a service to the population that was actually commissioned to serve, and most importantly, the participants' narrative suggested that the aftercare service was meeting its objectives and making positive impact on the outcomes for clients and their kinship. Steve's got to go, but we thank him. He's got another meeting, but thanks for being here with us.
Thank you. All the best.
Thanks, Steve.
Thanks, Steve. Thank you very much. Okay. Well, thanks, Shay and Steve. I need to thank Shay twice. She's taking a part in a number of these presentations. So the Aboriginal Aftercare Service has been quite a groundbreaking service for our area and has established a model of care, I believe, that can be implemented in other communities, Aboriginal communities across Australia, of course, with the consultation of that local community. You can't necessarily pick up a service and plant it somewhere else. You also need to consult with the community. Now I'd like to introduce Hayley. Hayley Collier is the Project Officer for the National Suicide Prevention Trial, and like Shay said before, has put 110% into her role and supporting the trial throughout her tenure. So Hayley's going to talk about the Youth Aware Mental Health Evaluation findings. So welcome, Hayley. Do we have Hayley?
Oh my gosh, I've been presenting. Sorry. Didn't realise I was on mute. Let's start again. Okay, so thanks everyone. So today I'll be presenting the findings from the Youth Aware of Mental Health YAM research trial that was conducted by Country SA PHN as part of the National Suicide Prevention Trial. I would like to thank and acknowledge the support received from the Black Dog Institute and acknowledge and thank the schools and students who participated in this study. Jess, I might need you to go to the next slide, please. Thank you. So what is YAM? Youth Aware of Mental Health is a universal mental health promotion and suicide prevention program for 14 to 16-year-olds. It encourages young people to learn about and discuss everyday mental health. It promotes peer support and provides youth with a guide to resources in their local community. The overall goal of the Country SA study was to assess the effectiveness of the YAM program in increasing help-seeking behaviours, reducing suicidal ideation and suicide attempts. The secondary aims of the project were to investigate the program's impact on suicide literacy. The Country SA study took place in 3 schools and was delivered to over 260 Year 9 and 10 students over the course of 2 years. All 3 schools participated in the evaluation of YAM, and participating students completed a questionnaire at 3 time points: baseline, post-intervention, and 6-month follow-up. The primary outcomes we are looking at is a reduction in suicidal ideation and an increase in help-seeking behaviours. Secondary outcomes included a reduced stigma towards suicide, increased knowledge about suicide, and a decrease in depressive symptoms. So just to break it down and give you some demographic characteristics of the sample, the average age was 14.7 years, predominantly female, and mainly English speaking. The following results that I will report on are based on the student's self-report at each screening point. I will report on the significant changes first, alongside the figures, and then I'll report on the non-significant results just in dot point form. So the Pike-Hall Suicidal Feelings in General Population Questionnaire. This questionnaire is used to assess suicidal ideation, suicide intent, and previous attempts, although previous attempts have not been reported here. Items are rated on a 5-point scale with total scores ranging from 4 to 18. High scores indicated a greater degree of suicidal ideation. Examples of items on the scale include whether the student felt that life was not worth living or whether they had wished they were dead. Analysis showed that there was a significant reduction in students' passive suicidal ideation from before they participated in YAM to post, and then further reduction at 6-month follow-up, which is what we wanted to see. So that was really great. The second outcome was the Patient Health Questionnaire Depression Scale, so the PHQ-8. This scale is used to assess depressive symptoms. Items are rated on a 4-point scale, indicating how often the student has been experiencing symptoms during the past 2 weeks. Total scores range from 0 to 24, with higher scores indicating greater depressive symptoms. Analysis here showed that depressive symptoms decreased from pre to post intervention. However, they began to slightly increase once more at 6-month follow-up. And the General Help Seeking Questionnaire is used to assess intentions to seek help for personal or emotional problems. It covers 11 different formal and informal sources, such as friends, parents, psychologists, teachers, or GPs. Students indicate how likely they are to seek help from each of the sources on a 7-point scale, total scores ranging from 10 to 70, with higher scores indicating a greater likelihood to seek help for personal or emotional problems. Analysis here showed an increase in students' likelihood to seek help for personal and emotional problems from before they participated in YAM, right through to the 6 months after they completed the YAM program. So there were a number of outcomes that showed an improvement post the YAM training. However, a 6-month follow-up showed no significant changes. Suicide literacy showed a slight increase in students' general suicide literacy from pre to post intervention. However, literacy was shown to decrease further at 6-month follow-up. Symptoms of generalized anxiety, students averaged a score of 7.6 prior to YAM implementation and dropped to 7.1 at completion of YAM. However, at the 6-month follow-up, scores had returned to the pre-screening score of 7.6. With the no significant changes, we'd just like to highlight that these learnings from the study revolve around barriers and external influences. The ability to keep outside factors consistent during the study was difficult. Schools were undertaking the training at different times of the year. External factors such as school exams, sporting finals, and the days of the week when the survey was undertaken all could have influenced the participants' response and learning capabilities. Throughout the implementation, we noted that depending on what subject the survey replaced, highly affected the students' attitude towards the survey. If it was a subject they enjoyed, they were not willing to participate and cooperate, which may have influenced their responses. We also found that the returning of consent forms was another issue, with over 50% of the students not returning the evaluation consent form, resulting in a decreased sample size. However, overall, the expected primary outcomes were achieved for this study. So whereby we saw a reduction in suicidal ideation and an increase in help-seeking behaviour was evident in the students who participated in the YAM program and the evaluation. Thank you.
Thank you very much, Hayley. Again, some very interesting results. And for me, the result of some of the findings around the 6-month follow-up period tells me that the importance of continuing to the need to continue to reinforce the message. Sometimes while the message is being reinforced over a period of time and then it stops happening, in a structured way sometimes, then we do forget. However, the whole overall outcomes were excellent. Now, I'd just like to remind everybody to take a 5-minute break. We're going to take a 5-minute break just now, and remind everybody to have a drink or have a stretch, and we'll be back at 11:05. Okay? Thank you. So welcome back, everybody. Now we're going to go into the Q&A, the question and answer session. And as mentioned previously on the panel today, we've got Shay, Kate, Nicholas, Hayley, and Richard Parker. So what I might do to start with, can I remind everybody to put some questions in the chat? We don't seem to have any as yet, but what I might do to start with, I'll get each of the panellists to introduce themselves again and talk a little bit about their involvement in the trial. So if I could start with you, Nicholas, would that be okay?
Yeah, absolutely. I think there's so many great takeaways to think about in the work, the enormous amount of work that's been happening locally. And I guess the first thing is to focus on the local and focus on community-led, community understood, and community believed activity. And if you think about the greatest challenges we face in suicide prevention right now, stigma is one of the greatest ones in terms of shifting people's perceptions. Maybe there are times when people have traditional perceptions around suicide and critical moments of the suicide experience. And what we've got here is a really good example of increased community awareness, ways in which there can be helpful guidance at the community level for community members when responding to people in distress. And what I tend to think of is, if you deal with those challenging aspects of stigma really well, and you bring people to some fresh thinking about their understanding of suicide-related distress, you actually help people know how and when to move in new ways. And when people know how and when to move in new ways, when it comes to understanding and responding to critical moments of the suicidal experience, they redefine the purpose of small talk. They redefine the purpose of compassionate leaning in and listening in. And they really redefine how they can make a difference, create a sense of connection and hope in somebody who might be struggling. And I guess that's probably going to be one of my greatest takeaways from all of this material, all of this incredibly important work, that there is increased compassion and awareness. Stigma has been addressed head on, so to speak, but at the same time, there's community engaged, leaning in and listening in, improved confidence to communicate and connect with people in distress, and decreasing that sort of judgment that can be a showstopper, a blocker for help seeking and also help offering when people respond to someone who might be struggling. So yeah, thank you very much for the opportunity to be here today and make those comments.
Thank you, Nicholas. And I think you've hit a number of points that are so relevant to suicide prevention. And as a member of a rural suicide prevention network and our involvement in the trial over the last 4 years, I think I've noticed a real significant way of bringing community together and to be able to trial some of our ideas and have the opportunity to engage with the community. So with that, I'll invite Richard Parker, who's sitting in the office with me here today. And Richard's has a lived experience of suicide, but Richard is also a member of our wireless suicide prevention network and has quite a lot of stories, but I'll invite Richard to share some of his thoughts of being involved in the trial. And also remind everybody that please, if you have any questions, don't hesitate to put them up in the chat. Thank you.
Hi, my name's Richard. I have a lived experience of suicide. I'm a suicide attempt survivor and local mental health advocate and member of the Wireless Suicide Prevention Network. And I was the coordinator of the World's Biggest Comic, which in a nutshell is a sort of a giant public art project involving local people. And we created a mental health narrative around the 5 ways of wellbeing across 15 sites, and created 600 metres square of public artwork for people to engage with. And a lot of different side projects were part of that, using community development principles to engage with as many people throughout the process as possible. So yeah.
Thank you, Richard. The World's Biggest Comic project is one of the biggest projects that the Wireless Suicide Prevention Network has taken on, and it was, you know, we thought, well, this is a huge project. Well, I don't think we realised how big it was when we first started, did we? But we took it by the horns and ran with it, and it's had a marvellous impact on the community. Shay, as another member of the Q&A panel, would you like to talk a bit about your involvement? And I know you wear a couple of hats in this space as well. So
thanks, Lee.
Over to you.
Yeah, I think what really struck me about the trial was the suicide prevention networks that were already set up in regional South Australia really wanted to increase their skills and be actively involved in all stages of the trial, and stayed with us for the whole of the trial. They did a lot of heavy lifting. They were the avenue and the levers and the infrastructure to push out community awareness raising and stigma reduction activities, and they were the ones that really wanted to take that on board. But they couldn't have done that without a lot of our national peak bodies that had done a lot of work in creating some evidence-based trainings and some strategies as well. So as much as we had the suicide prevention networks that are made up usually of volunteers and community members, lived experience representation, and also some service providers and stakeholders, we still needed that evidence base that was created and provided by some of our national peak bodies. And you can see there that through the training and the amount of living works training suites, and then the amount of evidence-based opportunity that come out of the Black Dog Institute, it really supported the networks to be able to ramp up a lot of activity in each of the regions. And I'm not sure if people have received an email from Hayley this morning, which is the actual executive summary of the evaluation, but in that you'll notice that all of the pictures in there, barring 1 or 2, are local regional South Australian people that wanted to be part of the trial and share messages for hope and recovery and share their lived experience, which is also really powerful because that just wasn't happening before the trial as well. So for those people to put their hands up and become advocates and heroes in their own communities was really important, and we thought it was nice to round out the end of the trial by featuring them again as well. Some of the other bits, I guess, I take away from the trial, which is really, really important, is some of the change we've been able to affect at a state and local level, but also strengthening the knowledge of those regional communities. It did change the landscape, and it will be changed forevermore from the activity that's went on and everyone that's been involved.
Thank you. Thanks, Shay. I think it's been it's provided massive opportunities for our local communities, and also we can demonstrate now some of the work that we've been doing at a national level. Kate, I'd like to invite you, Kate, as an evaluator that actually came and visited our communities throughout the evaluation, and it'd be lovely to hear, Kate, from all the wonderful research that you've provided and evaluation that you and your team have done throughout and provided us with some documentation, but also what it was like for you to come out and talk to people might be interesting to share and hear some of those stories. Thank you, Kate.
I think, thank you, Lee. as an outside observer, I was someone coming into the evaluation not realising the scope of what had been implemented. And I was coming into the communities, I was really struck by the increase in the community capacity to reach out to each other, because I think that's so important. And as Shay said about the heroes in their own communities, there were heroes in the communities who, you know, other people in the communities could reach out to, because sometimes, you know, their services or their support person might not be available, but they felt comfortable because of the raised awareness and the reducing of stigma to reach out to people within their own community and seek help, just to talk. And those other people, the heroes, were quite happy to have strangers come up to them and ask for help and put their hand out for help. So, you know, I was really struck with that. I think that also, having lived in rural communities myself, I know that they're quite more supportive of each other as well anyway, in compared to urban, suburban living. So that's something I was really struck by. I think if the theme of World Suicide Prevention Day is creating hope through action, that the trial has really achieved that and hit the nail on the head, and done that through multiple ways. And the scope of this is really big, and I think the response has been excellent, and it's been so good to be looking at the data and seeing all these positive results and talking to the people in the communities. Because when I'm sitting here in Adelaide and I'm seeing the results on the stats, and I'm going, what is this world biggest comic book? Why is a book so successful? Why are people talking about this? It's a book, you know. And then when I get out to Whyalla, I can see, oh, this is the book, you know. So we walked around and took pictures of the comic book, which were these massive murals on canvas on walls with messages of hope, and paintings that were beautiful artworks of the people in the local community. So, and similarly, you know, going to visit Aboriginal people in Port Augusta, we could see how the funding that they had got to reunite mothers with their children was just fantastic. Given, you know, the effects of intergenerational trauma with Aboriginal people, I was, you know, just so moved by what's happening there at the local level. So thanks. It's been a real privilege to be come and do this evaluation. Thank you.
Thank you, Kate. I'd just like to ask Richard if he would mind sharing some of his experiences project managing the world's biggest comic. Richard, one thing I was thinking about when everyone was talking was that, you know, we did some fantastic projects really on small amounts of money, which required a lot of volunteer hours. And I'm speaking from my experience with in my role as on the Wireless Suicide Prevention Network. However, I imagine or know that this would have been similar across all the programs that were filtered through the networks. And the volunteer hours are enormous. And people get quite passionate and committed to doing this. And like Kate said, it follows the theme of World Suicide Prevention Day today, with hope and, you know, creating action to build that hope and instill that hope. So Richard, I'm just wondering if you could talk a bit about some of your good and challenging experiences of project managing the comic book.
Yeah, the comic book project was based on community development principles, and I'm very passionate about community development as a model. It's difficult to measure, unfortunately. It takes significant time and resources to build up respect and relationship within a community, which had already been done to a large extent by the Wireless Suicide Prevention Network coming into the project. There was a lot of goodwill that we could draw on when we were engaging with local businesses, local artists and community members who donated significant amounts of time towards the project. We sort of, the Wireless Suicide Prevention Network did something quite radical, I think. And that is they gave the reins to someone with mental health issues, which was me. basically. Someone with a lived experience, but someone who still struggles with depression, still has down days, difficult times, someone who still struggles with anxiety from time to time. But they had enormous faith in me and provided me with a wonderful support network that I could draw from throughout the project. And that enabled me to take this crazy idea that we had and develop it and think about ways of expanding it and take on risk throughout the project. Many traditional organisations and bureaucratic institutions are naturally very risk averse. So something that I was thinking about throughout the project is how can we include more people? Who is missing from this project? Can we include people with disability? Can we include people with lived experience of mental illness? Can we include artists from Aboriginal background and make them central to the story and the narrative of the comic? How can we include school children in the project? This came in the sort of last quarter of the project. I was thinking, how can we include young people in a meaningful way? People from LGBTI background. We were trying to focus on the process, and I kept coming back to the process as result rather than the end outcome. So even though the rollout of the project had some issues in terms of timing, in terms of some canvases falling off the walls sometimes and technical stuff like that was very challenging. If we keep coming back to the actual process we went through in terms of funding local artists to participate, in terms of involving local people in the project, in terms of all the conversations that happened throughout the period of the world's biggest comic, and all that awareness raising along the way that is often lost in statistical analysis. I think these are super important things to talk about, and how it strengthened us as a network as well. I feel like we're friends and we're a family, and I've had moments in this project where I've just felt indescribably loved and supported, and like people have actually believed in my wild ideas and sort of ability to think in unconventional ways, and I've just felt so accepted throughout. So it's been an absolute honour and privilege to take some of my lived experience and be able to turn that into something positive, and hopefully something that's impacted somebody in a positive way. So
thank you very much, Richard, for sharing that. I'll just read out a couple of comments that have come through on the chat. There's some comments around expanding the YAM program within the Department of Education. However, unfortunately, at this point in time, COVID has delayed this, as the trainers are based in New South Wales. When I read that comment, that reminded me of the world we're living in right now, and the impact that COVID and having to isolate and the change in lifestyle, even the small requirement of having to wear a mask does impact on us. And again, that feeds into that theme of hope, and we're continuously hoping to move forward. The other thing that, and someone else has also commented on the executive summary being very good, thank you. And the impact in schools has been helpful, as we also are seeing significant benefits around our school counselling program. So these comments, keep them coming, because they're very encouraging, and it's really good to hear. The other thing that and I direct question to Shay and Nicholas maybe, is when Steve was talking about the Aboriginal Aftercare Service, he made a mention of and I'm not sure if I heard it correctly, but he made a mention of the K10 being used, and these assessment tools that are actually being used as part of the model of care within the aftercare service. And that triggered a thought for me. If that is the case, then I don't know if it came out in the evaluation, but or even if it was looked at, but it raised the question of having culturally appropriate assessment tools to being used. And I just wondered if Shay, and I know I've pulled Nicholas into this because I know he has done a lot of work in the cultural space as well. So just wondering if there are any thoughts on that. Shay, do you want to?
Yeah, just
Nicholas?
quickly before I hand over to Nicholas, what I've done is, because I'm not sure people are aware about the comic book, I've changed my screen behind me to one of the comics, which is the whole size of the Whyalla Hospital, many stories high. These aren't little installations, these were massive. So there's one behind me there that takes the whole side of the Whyalla Hospital. But also, yes, I guess in relation to outcome collection, there was a need to have some consistent outcome measures across the whole of the trial, but what that meant that some of them weren't probably adapted or appropriate for specialists or priority populations. So what we were able to do for the Aboriginal and Torres Strait Islander services was to, instead of using K10, use a K5, which is adapted for Aboriginal communities, but then the CIDA scale. But even with those approaches, it was still challenging to capture them. And I think there does need to be more work done on a national landscape around appropriate capture and effective outcome tools. Over to you, Nick.
Yeah, look, that's a great question. And as it happens, it was the focus of quite a bit of discussion last night on the ABC television program, The Drum. I don't know if anyone managed to catch it, but it's probably available on iView. Yeah, there were a couple of people. Tom Karma was one who was commenting on exactly this topic, and certainly the strong takeaway for me in tuning in on that discussion was, as Shay's just said, there needs to be more work, there needs to be consideration given to culturally appropriate measures. But there's another aspect that I wanted to briefly just capture, and that was the importance of personal stories and individuals' experiences. And I think that's something that features across all of the material that's been presented today. The way in which individual stories and experiences of distress, suicidal thoughts or attempt, and periods of distress or crisis can be shared in a sensitive and appropriate and a thoughtful way where people feel safe to be able to share them. And I think that when you look at the experiences of being involved, people are sharing experiences of being involved in different activities at the local level, all of those insights go a long way to helping others understand what it means to not only feel suicidal, but also to actually get help and maybe deal with some aspects of internalized stigma. Maybe there's some aspects of, I can't ask for that, or I don't feel right, or I feel a burden to others if I ask for that. But stories that can demonstrate how people live through and with those difficult times. And I think those sorts of processes really come through in the material that certainly the UniSA team, Mental Health and Suicide Prevention Research Group team, looked at, and the importance of personal stories telling. And I know Shay and Hayley, you did consider the idea of maybe doing some short videos down the track, about how people who've been involved in the trial, participated, who've helped others understand suicide better, maybe respond to critical moments of suicidal experience, what that's meant for them, how they've been able to reach out. And, maybe there's some great value to be gained in pursuing that if there's funding available. So.
Thank you very much, Nicholas. And I think it's really important to highlight the importance of personal stories. And they just mean so much. They become so real when you hear someone's story and how it's related to a program that you implement. A couple of other comments coming through, people thanking us for the evaluation. Great to see the impact and motivating to develop our capacity further to work with Assist and Safe Talk across South Australia. And the school counselling within public school systems is still relatively new within our community. And this has seen early intervention for young people that provides the support for young people's worlds, which includes identifying suicidal ideation. So we're coming to the end of the webinar now, and I'd like to thank everybody for attending, and personally thank the evaluators for the great work that they've done with the evaluation, and Shay and her team, Hayley and many others, and all the people with lived experience across South Australia that participated in the evaluation, and the service providers, the businesses, everyone who participated. I'll just hand over to Hayley. She's raising her hand.
Yeah, I can see all of the questions are shooting away in the chat just around YAM and the expansion of YAM. So just to give a bit of context, we trialled it in 3 schools, one of them being on the Yorke Peninsula. So we do have a trainer based on the Yorke Peninsula currently. With YAM, there's quite a high fidelity in making sure that it's delivered correctly, and we can't have teachers delivering into a school where they actually teach. It has to be an external educator going into the school. We currently have 6 trainers based in SA, and the plan was to upskill a further 15. But to do that, we need the trainers to come over from New South Wales to train the new trainers. So at the moment, we are still exploring that. COVID definitely is a huge challenge because training has to be delivered face-to-face. We can't deliver it over Zoom, unfortunately. But the Department of Education has been really supportive, and they're really keen to continue exploring expanding YAM as well throughout Country SA. So it's on our little task list, and we're working really hard to make it happen. However, the good old COVID has really thrown a spanner in the works with that one. But we will be exploring how we can make something happen in the schools, because yeah, so to me, I loved working on the YAM project, and to see the results, it's great to see something's working. So thanks for the questions, guys.
Thank you, Hayley. A whole suite of questions flew in right at the end there. With that, I think congratulations to everybody, and thank you everybody for participating. And I guess we close off and say goodbye, and I hope everyone has a wonderful day today with it being World Suicide Prevention Day. So Richard and I will say goodbye from Bungala country, and all the best. Thank you.
Bye.